Hi, I'm Dr. Anthony Pinto, licensed clinical psychologist and program director of the Northwell Health OCD Center at Zucker Hillside Hospital, located on the campus of the Long Island Jewish Medical Center. I'm really pleased to be with you today. Thank you for your interest. Today, I'm going to be talking to you about understanding and treating obsessive compulsive personality disorder, otherwise known as OCPD. OCPD is a commonly occurring condition in the general public. Some studies suggest that it may be as many as 3 to 8% of the population, and it occurs even more frequently in clinical samples. Yet, despite its prevalence, there's much that the public doesn't know about it, and even clinicians are not as familiar with how to treat it. So today, I'm going to be telling you more about what it looks like in terms of its clinical features, how it gets in the way of an individual's functioning and causes problems in relationships. And then we'll be talking about how to differentiate OCPD from OCD, which is a common misunderstanding. And then finally, we'll talk about cognitive behavioral interventions for the maladaptive traits and behaviors of OCPD. So let me share my slides with you now. Okay, so understanding and treating OCPD. If you'd like more information about OCPD, I'd encourage you to take a look at this book. It's an edited volume, the first of its kind, called OCPD. I edited this with two of my colleagues. And the book also includes a chapter on cognitive behavioral therapy for OCPD that I wrote, which may help give you more information about what we're going to talk about today. All right, let's do an overview of OCPD. So OCPD is a personality condition. So it's, which means that these are going to be an enduring pattern of traits and behaviors that are going to be existing in a person's life for a period of years. And so some diagnostic manuals suggest that these should be present for at least 5 years. And not only are they enduring, they're also causing clinically significant distress as well as functional impairment, which we'll talk more about. To get the categorical diagnosis of OCPD, one needs to have at least 4 out of these 8 criteria. And then we'll talk about some additional features as well. But again, the categorical diagnosis means 4 out of the 8 of these. Yeah, but there's more of an interest in the field now to look at how these various traits do on a continuum. So even in individuals that have fewer than 4, it may still be relevant to think about these traits because they may be impairing. So let's talk about the different diagnostic criteria. So number 1, a preoccupation with order, details, and rules. So these are individuals who are fixated on order, which can be like the physical placement of items because they like it that way. It could be the way their items are arranged on their desk or in their closets. They might spend a lot of time putting clothing in a certain order, arranged by the day they're going to wear it or by color. They're very fixated on details. So when they're making a decision, they like to gather a lot of information, which slows them down. Or when they're going to do a project, they like to have all of their materials, which again, takes a lot of time and effort. They're fixated on lists, and so they tend to be hyper scheduled and like to know what they're going to be doing throughout the day, and can be irritable if their schedules are tampered with. So number 2, self-limiting perfectionism. So perfectionism is one of the hallmark features of this condition, and it means that they have unreasonably high standards for themselves in terms of the quality of their work, and those high standards get in the way of task completion. So they may, if they're students, they might be either pulling all-nighters in order to get projects done. They might be asking for extensions of their professors because they need more time. And it may be that they have difficulty starting because there's a lot of anxiety because they want it to be done a certain way, or they maybe have a difficult time saying when something is done because they feel like they could always add to it. It could always be better. Um, they have an excessive devotion to work and productivity. So it's hard for them to have time off, hard to take off time from work. They feel like they are indispensable and that things won't function well if they're not there. Um, they may even have a tendency to turn leisure activities into work. I had a patient that had difficulty like playing Legos with his kids because he felt like the buildings had to be a certain way, and so then it became less fun for him. Another person I worked with uh, enjoyed throwing the football, but he had such high standards for how the football would be thrown that he ended up like recording himself and watching it in slow motion so that he could really examine the mechanics of how he was throwing. They have an inflexibility about morality and ethics. So there's a tendency to be judgmental of other people in terms of morals and ethics. Um, they may get into campaigns for how things should be in their community. So while many people might be motivated to recycle, these are people who will not only want to recycle in their own homes, but they might go in through other people's garbage to make sure they are recycling. So there's, again, there's a lot of time and effort put into these things, which gets in the way of doing other things. Um, there's an inability to discard worn out or worthless items. So for many of the individuals I've worked with, they have difficulty discarding papers. And it's because they have such a intense, deliberate way of reading that it takes them a longer time to get through things. And so they save up magazines and newspapers, article clippings, thinking they're going to get to it eventually, but often never do. They might hold on to other items related to projects that they think they're going to get to. So this is related to like a time management difficulty. There's a reluctance to delegate tasks. So this may show up at home, wanting to make sure that they do all the chores, wanting to make sure that they are the one to load the dishwasher because others are not going to do it in the way they do it. At work, they may really dislike group projects or at school because they either will want to do all of it or if they do assign tasks to other people, they will micromanage the others, or even redo the work of other people. Another trait is miserliness, meaning it's almost painful for them to spend money on themselves and on other people. So they may have a hard time buying things for themselves, a hard time buying gifts for other people, even when they have the money. And so if you go out to dinner with them, they'll want to divide the costs down to who ate what. Um, and so again, spending is an issue. Wanting to maximize and make sure they get the best deal and the most value when they spend their money. So again, it slows things down and can be very irritating to those that live with them. Rigidity is another common feature or core feature of OCPD. Stubbornness, it's hard to sway them once they've made their decision about something. There's an insistence about one way of doing things or wanting to control. And so that's another thing to look out for. Let's look at some associated features to OCPD. So these are not diagnostic criteria, but they're still important things to look out for. Indecision, so a fear of making the wrong choice. This is something that you'll particularly see in making purchases. So they, Amazon is really creates a lot of problems for individuals with these traits because they will want to read all of the reviews. They will do excessive research and look at many options before they decide on what they're going to purchase. And it's not just purchases; it may be decisions about that are difficult for them about how to spend their time, or decisions about what to do socially. They have a difficulty with change, and so they can, like I said earlier, they can be irritated if their schedule is tampered with or if somebody cancels on them at the last minute. They tend to be excessively rule bound and like routines, like doing things the same way, even when it's not efficient. They have difficulty relating to and sharing emotions. So they may be perceived as being detached or emotionally unavailable to their partners. And so sometimes patients will tell me that they can they can read the emotions of other people, but they have a hard time knowing how to respond to those emotions. And some will even say that they feel like emotions are a waste of time, and so what's the point? Um, while they tend to be emotionally over controlled, they can also have anger outbursts when their sense of control is threatened. So that another thing to keep an eye out for clinically. And then finally, procrastination is a big part of this condition, and because they have such high standards, that they will put off doing things because there may be some anxiety about doing it the right way or the best way, and so this causes them other stress because then they get behind on things and causes difficulty for them, whether at school or at work. So another thing we talked before about, like the slowness with regard to reading. They have a detailed way of processing information, whether it's written, it could even be like visual information, because they fear they're going to miss out on things. So a lot of the individuals I've worked with these traits have given up pleasure reading because it's too slow and takes too much effort. All right, let me show you some pictures that will help give you a better understanding of this condition. Uh, I like this one because it really shows the methodical intensity with which they approach life, and the tense deliberateness which they approach tasks. And so this example here really gives you the sense of like losing the forest for the trees and like really hyper focusing on details. And it shows you how time consuming it would be to get anything done if you have this, if you're looking at the world through this lens. This is an example of like the need for order and routines that some of these individuals can exemplify. And so this particular person would plan the meals out, every meal for the week. And as you can see, there's like certain rigidity about needing to have certain items, the same items on those days. And so even it can affect like how they handle their diet. And so this person had a lot of difficulty if for some reason they couldn't eat these meals or if they were presented with other food. Another thing to think about with regard to these patients is even in terms of how they communicate. So they have a tendency to over-explain things and over-qualify statements. A patient of mine actually gave me this. And so rather than having a single thought, the bottom half of this drawing shows you like how they view the world, and that they will see so many different variations of a particular thought, which could even be in terms of how they approach doing a task. And they may see so many ways of doing it, but then there's like a paralysis of indecision about which way I should go. And so when you ask them a question, there's a tendency to overqualify statements and to avoid being definitive or absolute. And that can frustrate people. And sometimes it can be like hard to, to follow because they're trying to let you know all of these different like sub thoughts and different iterations of their thoughts. And finally, this cartoon really gets at the interpersonal problems that are part of OCPD. And so here, the one person is saying, "My New Year's resolution is to stop telling you what to do all the time. Here, I wrote down your resolutions for you." So again, this gets at like this like control aspect that you can see in OCPD, which can be really difficult for partners. This is a case example of OCPD, and so we'll call this person Betty. She's a 30-year-old married school teacher. She would not let anyone touch her book collection, which was really dear to her. She insisted that her husband get into bed first at the end of the day. And what was most memorable about this case is that not only did she want him to get into bed first, she would actually tuck him into the bed so that she could be the last one to survey the apartment to make sure everything was where it was supposed to be. She was unable to modify her routine of getting ready even when she was late. She refused to allow others to help her do tasks, and so this is that difficulty delegating. She insisted on driving or walking the same predetermined route, which was, and what was notable is even when they were on vacation, she would plan particular routes and would not want to stray from them. She was critical of other people taking shortcuts, and so there's the morality aspect, and this led to conflict with her husband and her coworkers. So in the years of working with these patients, it's become clear to me that there's heterogeneity within this group that we call OCPD. And so what that means is that I tend to see different types of OCPD. And so uh, one thing that I've started to think about is that perhaps there's a hostile dominant type of OCPD and then a more anxious type of OCPD. And so I work in an OCD center, and in this placement, the individuals that present that have OCD as well as OCPD tend to be more the anxious type. Uh, but I've also worked with individuals that are in this more high control, hostile dominant type. So I'm just going to go through some differences between these two types. So behaviorally, the hostile dominant type tends to be more the workaholic. They're the ones that may be the higher risk of self-harm. And so there was a study that looked at individuals that had depression, and those with OCPD did have a higher risk of suicidality. Um, and they tend to be verbally hostile towards others. Whereas the anxious type are also workaholic, but more procrastinators, more socially avoidant, more tendency towards sleep disturbance. Um, on the cognitive level, I mean, in terms of their thinking, the hostile dominant type is more perfectionistic towards both themselves and other people. So they might be mistrustful of other people, somewhat eccentric at times, whereas the anxious type is mostly inward perfectionist towards themselves, self-critical, which can also impact their mood. They over-attend to not meeting the expectations of other people. Um, on the affective or emotional side, the hostile dominant type are irritable, chronically frustrated, feeling like the world is always letting them down. People are never meeting their standards. They tend to have a negative temperament, difficulty with emotion regulation strategies and accepting emotions. Whereas the anxious type, as the name suggests, are anxious. They tend to, because they're internalizers, have somatic symptoms such as like irritable bowel syndrome. They tend to be prone to worry. Generalized anxiety disorder can also be a comorbidity here. On the interpersonal level, the hostile dominant type are hostile, critical, judgmental of other people, rigid, controlling. They have been described as being lower in empathy, more detached and emotionally unavailable. Whereas the anxious type has a tendency more towards being submissive and avoiding of intimacy. So keep in mind those different types in thinking about these individuals. So one of the questions I get most often is, how does OCD differ from OCPD? How are these things the same? And so one thing I just want to be clear is OCD and OCPD are distinct conditions, but there is a relationship. And so there are elevated rates of OCPD comorbidity in OCD samples. So that means when you look at individuals with OCD, about a quarter to a third of those individuals will also meet criteria for OCPD. There's also a higher rate of family history of OCPD in the first degree relatives of individuals with OCD. And some studies suggest that individuals with OCD are twice as likely to have OCPD in their first degree relatives, meaning parents as well as siblings. And so there's definitely evidence for a relationship between these conditions, which is something that needs to be further studied, because maybe there is some common genetic abnormality, maybe there's some common neurological pathways that can be examined. There's an overlap in the symptom presentations, which can make it difficult to differentiate the condition. So ordering rituals in OCD, so meaning an individual with OCD who needs to order things in a very particular way or arrange things in a particular way, that can look like the preoccupation with order or details that you see in OCPD. Incompleteness, which is a phenomenon of feeling not just right in OCD, can look similarly to perfectionism in OCPD. And then hoarding, which was once subsumed under OCD, is a behavior that you see in OCPD. And so that was another area of overlap. And since the DSM-5, hoarding is now considered, it's a separate condition, hoarding disorder. So traditionally, the main way that OCD and OCPD were differentiated was in terms of the patient's experience of the symptoms, or in terms of the function of the symptoms. So OCD was considered to be an ego-dystonic condition, meaning that the obsessions and compulsions in OCD are seen as foreign or separate from who the person is. The individual with OCD finds the intrusions in OCD to be distressing and unwanted. They don't want to be doing the compulsive behaviors, but they feel they have to in order to ward off the feared outcome, or to be able to decrease their sense of anxiety. So the symptoms are seen as separate from who they are. Whereas OCPD, being a personality condition, the traits and behaviors are considered ego-syntonic, meaning the traits and behaviors in OCPD are seen as part of who the person is, how they see themselves. Some of these individuals would also argue that other people should be this way. And so that's a main difference between how to differentiate these conditions. So I had done some research, several years ago, comparing samples that had OCD versus samples that had OCPD. And what I found in that study is that both conditions were considered impairing, both in terms of quality of life and psychosocial functioning. So both are, having major impact on individuals' lives. Another similarity between these conditions is that they both were marked by ritualized behaviors that had to be done in a certain way. However, the core way in which these two conditions were different is in the presence of obsessions. So obsessions, which are intrusive or unwanted thoughts, that phenomenon, obsessions, was only found in individuals that had OCD. You do not see these intrusive, unwanted, anxiety-provoking thoughts in individuals with OCPD. So some examples of intrusions or obsessions might be a fear that I'm going to get sick by touching a public surface, or a fear that I'm going to hit somebody while driving, a fear that I'm going to do something that is offensive to God. So those are examples of intrusive thoughts or obsessions in OCD. You don't see that type of content in individuals with OCPD. In this study, I also was looking for another way to compare and contrast these conditions. And so my colleagues and I looked at various neurocognitive tests to see if there was another way that we could differentiate them. And what we found is in a robust way is that people with OCPD differed from individuals with OCD and from healthy controls in that they had an increased capacity to delay reward. So what that means is that they were given a series of choices, and would you rather receive some value, some amount of money today versus a slightly greater amount in the future. And the individuals with OCPD consistently and more frequently than their counterparts with OCD or healthy controls would consistently go for the larger amount, or the later amount, I should say, even if it was just slightly larger than the option presented, now. So individuals with OCPD, we can say, have an ability to delay reward, delay gratification, which seems to set them apart from individuals with OCD and healthy controls. And so this got me to thinking that maybe there's a continuum of self-control, where on one end, there may be conditions that are more marked by impulsivity, like substance use disorders, borderline personality disorder, pathological gambling, ADHD. And on the other end, there may be conditions of over-control, like OCPD, as well as anorexia nervosa. So this is something that needs to be looked at more, because this may be helpful in learning more about the brain mechanisms that underlie OCPD and over-control. So just to say a little bit more about that, we used to think that the relationship between psychological well-being and self-control was a linear one. So the more self-control you had, the better. And individuals that were low in self-control or under-controlled or with high disinhibition were the ones that had pathology. But as we think about this more, it may actually be that the relationship is a bell curve, and that so this relationship between psychological well-being and self-control tendencies, maybe the pathology lies in the two extremes, and that not only are those with under control or impulsivity going to have interference in their functioning, but the too much self-control may also be problematic, and that those with high constraint may also have difficulty, and OCPD would be in that over control side. And so the right balance, would be somewhere in between. So optimal control would be associated with greater health. So to think about that further, in terms of patients and their presentations, you can think about those that are under controlled versus over controlled. So on the under control side, more of the presentations that are dramatic and erratic, high and variable expressivity of emotions, a more tendency towards impulsivity and risk-taking behaviors, more chaotic and intense relationships, emotionally labile. So the under controlled, an example would be borderline personality disorder. And on the over control side, like OCPD, you have a tendency towards constriction and control, perfectionism, rigidity, a more inhibited, emotionally over controlled expression, more tendency to avoid risks, and so that goes along with the delay discounting finding I was just telling you about, where they, were more apt to delay reward. They have more distant and aloof relationships and tend to be more emotionally static. So this is one way of, sort of viewing patient presentations in terms of under control versus over control. So let's move now to treatment for obsessive compulsive personality disorder. So while OCPD patients often present for treatment, and I said earlier, this is considered a highly prevalent condition, unfortunately, there is no definitive empirically supported treatment for this condition. There have not been any controlled trials of psychotherapy or pharmacotherapy that specifically target OCPD. There have been some small open trials of supportive expressive psychodynamic therapy, as well as cognitive therapy. And more recently, there have been case studies looking at an adaptation of dialectical behavior therapy known as radically open DBT, which has been looked at in OCPD. So what I'm going to talk to you now is about cognitive behavioral therapy for OCPD, and I'll give you some examples of the interventions used. So for more information about this, there is a manual out called Cognitive Behavioral Treatment of Perfectionism, which I've been using with patients with OCPD. And it is the treatment of CBT for OCPD is also further described in the edited book, which I mentioned earlier, called Obsessive Compulsive Personality Disorder. So let's look at the so the different steps in the cognitive behavioral therapy. So number one would be a cognitive behavioral formulation about perfectionism and about rigidity. And so let me show you what that would look like. And so the the my colleagues Egan and et al. They conceptualize perfectionism as starting with this idea that one's self-worth is overly dependent on striving and achievement. And because of that connection that they make between self-worth and achievement and productivity, the individual has certain inflexible standards or rules that they develop. For example, some rules might be, I need to get all A's, or my writing must be flawless. So then the individual develops certain performance-related behaviors, such as overly editing papers or checking homework before turning it in, rereading emails before you send it to a coworker, all because they have these inflexible standards or rules. The standards are also being supported by certain cognitive biases like all or nothing thinking. So this conceptualization posits that there can be one of three outcomes when a person with perfectionism does a task. One is that they may temporarily meet the standard. For example, they might do well on the test, but then they will reappraise the standard as insufficiently demanding. So if they do well on a test, they'll say, well, that professor is not a hard grader, or everyone did well on that test. Or they may fail to meet the standard, which would lead to counterproductive behaviors and self-criticism, like negative self-talk, things like I'm a loser, self-punishment, sacrificing or depriving themselves of pleasures. Or they may avoid trying to meet the standard altogether by not turning it in or deciding I'm not going to do that because I don't think I'll do well. And all of this leads back to the self-worth concept being overly dependent on striving and achievement. So this is the conceptualization, and the treatment intervenes at various stages. First, we try to identify what the rules and standards are. We work with them to get a better understanding as to what do other people do, other people you respect. And so we'll talk about surveys in terms of how do other people handle their work, their school, or work in the office. And then we will work through behavioral experiments in order to challenge these rules and standards. All right, so number two, self-monitoring is an important part of this. We get them to monitor how often they are engaging in these perfectionistic or rigid behaviors. Surveys that refers to having them ask questions to people that they respect at work or at school about how long does it take you to do things, or what are the steps that you do when you research a paper or if you're making a purchase. The core thing, the most important part of this CBT process I should say, the behavioral experiments to challenge the standards or rules. So you can think of behavioral experiments as exposures, but we use the word experiment because we're really setting this up as if we were doing a scientific experiment. We'll ask them, so what do you think will happen if you don't follow this rule? And so for example, I had a patient in which the experiment was, what will happen if you go to work without ironing your shirt? He would iron his shirts every day, and that would make him late for work. So we'll ask, what do you think will happen if you don't, if you just wear the shirt, even with the wrinkles? And then have him set up an experiment, wear the shirt to work without ironing, and then let's see what happens. So the experiment is about collecting data in real time so that they can see how it turns out. It's not about me or someone else telling them what to do, like, no, that's a waste of time, don't iron your shirts, because that's not going to be helpful to them. They need to actually try it another way to see if it actually benefits them. um, I had a patient who insisted on ironing his sheets after he laundered them, and it took him hours to do that. And so we said, all right, let's try it without ironing and see what happens. And and so in the case of the bed sheets, he found, wow, that's several hours of my time that I've now gotten back. I can use it for my other values. And so that was his way of buying into the treatment. And so when you set up these experiments, it's important to think about, what do you hope the individual will gain from it? Like, is there, what would be the benefit to them to violating this rule? Um, is it going to save them time and so that they'll be able to use for other things? Is it going to help them cope with being uncomfortable? So I had a patient of mine who felt like after he took a shower that he could not sit on the couch because other people sat on the couch and he was in his clean state. And so we said, let's try it out, because if it turns out that you can actually tolerate sitting there, it gives you more flexibility in your life. You don't have to go immediately to bed after you take a shower. Maybe you can then sit and enjoy a show with your family. So there's, you want to think about, what is how is this rule or standard getting in the way of the person's life, and what can they gain from learning to turn that rule into something more flexible. So behavioral experiments are a really important part of this treatment, and it's really about collecting data to test the validity of a particular rule or standard, as opposed to an OCD where the exposure is really about trying to achieve safety learning and trying to show the person that if you do the exposure that that you know it's likely the bad thing won't happen, or that you will be able to tolerate the anxiety. All right, so beyond behavioral experiments, the treatment also includes challenging cognitive biases like all or nothing thinking, uh, mind reading, labeling, having them identify, these biases that they have in terms of thinking that impact their emotions. Procrastination, which is a big part of OCPD, is another part of CBT. We get them to think about deadlines and breaking down tasks and being really deliberate about what are you going to do. And so to get away from working in binges to working in piecemeal, like doing a small bit of something, then being able to come out of it and then go back into it, and doing that over days rather than trying to save up this bolus of work and like powering through the night before. Self-criticism is a big part of that conceptualization we talked about before. So we do try to work on self-compassion, having them build in time to do pleasurable activities, as well as like looking at other ways of defining yourself rather than just on productivity and on what have I achieved? Are there other ways that I can evaluate myself, so that if my work life is not going well, I have other things that can support my view of myself. All right, and so that's related to self-evaluation as well as relapse prevention, how to maintain these new ways of living. Some additional treatment components include an emphasis on values, right? So, so getting a sense as to what do you want your life to look like, what directions do you want your life to go in, and how is the time and effort that you're putting into making decisions or in completing your work, how is that interfering in the view you have of your life? And how can you reclaim time so that you can redistribute it to other things that you want to be doing in your life? So time management and scheduling, like I mentioned before, we want to get to a place where the things that the person is devoting time to is in line with their values. So they're not so imbalanced in spending all of their time working or all of their time doing like household chores, and try to redistribute that time. Have pleasant events, spend time with people that you love. So that is an important part of the treatment. And then finally, decision making. And so we will work through how to approach decisions by gauging their importance. How much time should you spend on that decision? And then after you settle on that choice, walking away from the decision without relitigating it and second guessing it or continuing to research after you've made the choice. So that's something we'll do in real time in the session. Have them pull out their phone, make a purchase without reading reviews, for example, on Amazon. So some quick case examples. Let me just check where I'm doing on time. Okay, just a few minutes. So I worked with a law student who had a lot of difficulty in writing papers. And so he would spend so much time gathering the source material for the papers that he left very little time for the writing itself. And so we worked through how to approach deadlines, and so that he was, leaving more time for the writing, and was working more consistently throughout the semester rather than saving up, closer to the deadlines. He also benefited from behavioral experiments that had to do with spontaneity. So he had to ride his bike around the city without any like plan or predetermined like location, just to be more present and to have a sense of adventure without being so programmed. I worked with a high school teacher who had difficulty with with keeping items perfect. She new items. She had a baby and she had gotten all these new things at her baby shower, but was afraid to use them because she didn't want to damage them. So we did experiments in which we walked in while she was pushing the stroller, and she pushed the stroller through dirt and mud, and so that she could really focus on the time with her baby rather than cleaning the wheels of the stroller. So she also had received pots and pans from her bridal shower, and so we started using them because she had avoided using them because she wanted to keep them in that pristine state. I worked with a professor who had struggled with a lot of self-criticism and procrastination, and as well as time management issues. And so he had difficulty with submitting papers for publication, which he needed for tenure. And so we worked on really starting his writing tasks because he avoided them. There's a conference room across the hall from my office, and he knew that if he didn't do the piece of the writing that we had agreed upon, that he was going to be doing it in that conference room, during the session. So those kinds of interventions, accountability, can also be helpful for those that have the procrastination difficulties. Leaving you a voicemail about what steps they took to do the work that you agreed upon in session. And then finally, had worked with a JD PhD who had trouble making decisions. That's why she went for two higher, professional degrees. She also had difficulties with criticism, both of herself and her spouse. And so she was able to, to really work on making decisions, both in terms of how she spends her time, big decisions, as well as should I have a child? And she ended up doing really well in the treatment. So in our final minute, I just want to go over some conclusions here. So the core features of OCPD include self-limiting perfectionism and rigidity. Individuals with OCPD report significant impairment in psychosocial functioning and quality of life. They report interpersonal deficits and difficulties modulating negative emotions. What I presented here today is that too much self-control can be as problematic as too little. Living with a loved one who has OCPD can be very challenging, and those individuals may need support to cope. OCPD should not be dismissed as an unchangeable personality condition. I have found consistently in my work that it is treatable with the right forms of cognitive behavioral therapy. So I would encourage you to use some of these interventions we talked about, to read more about them, because these people can do well in treatment when the motivation is there and you are aligned to the values that they want in their life. All right. So finally, here's my contact information. Please feel free to reach out if you have any questions about OCPD. I'm happy to talk further. Again, thank you so much for joining me today, and hope you've learned more about OCPD for yourselves, for your patients, for your loved ones. Again, thank you, and look forward to connecting in the future. Take care.